The next case for this panel discussion is a case of non-healing ulcer foot in a lady with type 2 diabetes for the last 10 years. For this deliberation, I would like to invite moderator Dr. Sri Nagesh. Sir is endocrinologist and diabetologist at the Sri Nagesh Diabetes, Thyroid and Endocrine Clinic at Hyderabad. We welcome you, sir. I'd also invite the panelists for this session. I would like to invite Dr. Ashok Kumar Athri, who is the professor and head of the department at the Department of Neurosurgery at GMCH Chandigarh. We welcome you, sir. I'd like to welcome Dr. Nishant Raizada. Sir is the Associate Professor of Endocrinology at the UCMS and GTB Hospital. We welcome you, sir. Now I'd like to pass the mic to our moderator for today, Dr. Sri Nagesh.
Good afternoon, respected doctors. At the outset, I'd like to thank the organizing committee of SPEEDCON for giving me an opportunity to be a part of this meeting today. And I'd also like to invite my panelists, Dr. Athri sir and Nishant, for the deliberation. So, for the next 2-3 minutes, I'm going to give you a typical case, the kind of patient would encounter in our day-to-day OP. A non-healing foot ulcer in a lady with type 2 diabetes for the past 10 years. To give you a brief overview of her history, she is a 56-year-old who is a homemaker, who's been diagnosed with type 2 diabetes since the past 10 years, who's been on oral medications, predominantly metformin 1000 mg twice daily, glimepiride 4 mg once daily, and vildagliptin 50 mg twice daily, and is a known hypertensive who's on amlodipine 10 mg once daily. She is presented with a history of ulcer over her left foot for the past 2 months, had minor trauma while she was clipping the nails. She had an ulcer around the great toe, which was initially a small abrasion, which ended up becoming an ulcer. She had redness and pus from the ulcer, which subsided after oral antibiotics. She is given history suggestive of diabetic neuropathy, paresthesia over both the feet for the past 3 years. And since the last 1 year, she is also complained of decreased sensation in both the lower limbs. The feet feel numb. Does not give any history of claudication or other cardiovascular disease. Has never been evaluated for microvascular complications of diabetes in the past, and also does not give any history of foot ulceration in the past. And this is how her examination was. She was in the obese category as far as the Indian BMI statistics are concerned. She had a large ulcer on the left foot measuring 7 centimeters by 5 centimeters, extending from the dorsum on the foot to the great toe and continuing onto the plantar aspect of the great toe and the medial part of the forefoot. She's got whitish slough on the dorsal surface with discharge, which suggests an unhealthy ulcer, a non-healing ulcer, and gangrene of the left great toe is also present. On examination, she had loss of fine touch and temperature sensations till ankle and graded loss of sensation till the knee. The vibration and joint position sense were absent till the ankle, and monofilament was not detectable in the right foot. She also had some evidence of vascular compromise, with dorsalis pedis not being palpable in both the feet. The posterior tibial artery pulsations are feeble in the left foot. An evaluation showed a very poorly controlled type 2 diabetes with an HbA1c of 9.1%, a fasting of 240 milligrams per deciliter and a prandial of 300 milligrams per deciliter. The hemoglobin showed iron deficiency anemia. The renal and liver function tests were normal. And she had evidence of hyperlipidemia with LDL cholesterol of 170. Triglycerides of 250, which could to a great extent be attributed to the fact that she had very high blood glucose levels. And the ankle brachial index was also a bit subnormal, with being 0.7 in the left lower limb and 0.8 in the right lower limb. To give you a brief summing up of this case, we have a case of type 2 diabetes with hypertension, with dyslipidemia, who's got a diabetic sensory peripheral neuropathy and perhaps peripheral artery disease, and a diabetic foot with a non-healing ulcer on the left foot. As far as the University of Texas grading goes, it is stage 2 and grade 3. The grading is given there for your understanding. And with this overview, I'd like to invite Dr. Athri to give us an understanding of the mechanics of diabetic foot ulcer. Sir, would you like to come over here and speak?
Yeah. You can see the spectrum of diabetic foot in this slide. These are our own patients. At Government Medical College in 2006, we established the exclusive center for treatment of diabetic foot and vascular diseases, and these are all our patients who have been treated. I'm thankful to organizers that they have made a surgeon a part of this August gathering, and to give you the overview how the foot can be destroyed by this disease. So everybody knows all diabetics after some time they are prone for diabetic foot ulceration. Their lifetime risk is very high, and it is unfortunately increasing very rapidly. Because of the incidence of diabetes is also increasing. You can see in your clinics that people are coming with this complaint, but unfortunately our physician colleagues, they have hardly any time, especially the busy one, to have look at the feet of these patients, and by the time they come to us, by that time the foot is already deformed or ulcerated. Basically the main cause in Indian setup is a neuropathic foot. Patient develops insensate foot, it gets hurt, it gets unnoticed, and then it becomes a full-fledged diabetic foot ulcer, and then necrosis of the whole foot may develop. Second is a combination of neuroischemic. In fact, in Western countries, it was initially ischemic part which was more predominant in producing the diabetic foot ulcer, and in Asian countries including India, it was more of a neuropathic foot. But now with change in lifestyle, we are seeing the combination of both of these two. It is a neuroischemic. So this figure which I have taken is not very much relevant to Indian setup. So whenever, the purpose is very clear to tell this slide that whenever you get a patient, the vascular assessment should be done. As Professor Nagesh told, that query peripheral artery disease in the index case, no, it should not be the query. It should be established by pulse examination and by duplex skin. And ischemic foot ulcer are exclusively sometime there, but the percentage is very low. There are so many risk factors like neuropathy, peripheral vascular disease, abnormal foot pressures. You know, with neuropathy, there are three types of neuropathy which can happen in this: autonomic, sensory, and motor. When there is a motor neuropathy, it alters the foot structure. So the pressure bearing areas of the foot, they get very high pressure because of the collapse of the arches of the foot. So this results into foot deformity, and then the trauma ensues. There is a sometime limited joint mobility. There may be a previous ulceration in the foot which also has changed the biomechanics of the foot, and which may make the foot more prone for ulceration and another point. And these patients, because of diabetic retinopathy, may have even poor vision to assess their feet. Old age also makes them impossible to inspect their feet. And duration of diabetes does matter. Mostly what we see in our setup is the diabetes more than 10 years. This particular complication, mostly patients, they come after a long diabetes duration. And cigarette smoking, which also is a factor for atherosclerosis, along with diabetes, produce havoc. These are the anatomical changes which can be seen in diabetic foot. There may be pes planus because of the collapse of arches, bunions may be there. There may be protruding interphalangeal joints, hallux valgus, bunions, Taylor's bunions, collar toes, prominent heads of metatarsals, thus making them prone for ulceration, pes cavus, and so pathophysiology I will not repeat. I have promised Dr. Nagesh that I will rush through the slides because this lecture itself is for 45 minutes. So I will just give you the overview of this. That's all these factors: neuropathy, vasculopathy, high blood sugar, they contribute in diabetic foot ulceration. Now, areas at risk of diabetic foot ulceration are pressure bearing area. More so is the head of first metatarsal, which produces lot of pressure at that particular area, and because of deformity, other areas they also start bearing pressure, and then they produce ulceration. There are so many classifications which have been used. University of Texas classification is one. Then there is another Wi-Fi classification, which in short is wound, ischemia, and foot infection. I will not go into detail of this. Then there is the most commonly used Wagner classification for the ulceration, describing the ulceration. And then if you see the biomechanics, how it changes with the changing time. This combined forces, that first slide was the normal biomechanics, but once the biomechanics of the foot changes because of the change in the architecture of the foot, the pressure bearing area, they become more prone for ulcerations. Now, this is biomechanical abnormality. Structural abnormalities are most frequently a consequence of neuropathy, and that is a combination of neuropathy, autonomic, sensory and motor. All three, they play a major role in that. These three, they need to be established, and accordingly the corrective measures have to be taken. Combination of foot deformity and neuropathy increases the foot ulcer, risk of ulceration. I will skip few slides of this because they are quite. Now, this is non-healing ulcer foot in a lady with a type 2 diabetes in 10 years. The one case, index case, has already been discussed. What actually we should be doing? We should take a detailed history, local ulcer and foot examination, vascular examination, neurological examination and examination of toe and nails. Then all the investigation which Dr. Nagesh has told should be undertaken. Vascular assessment is very important. It can be clinically by assessing the ankle brachial index. In that index case also, he has said it is 0.7. 0.7 is low. It means this is going to put a risk on the circulation, and ultimately it will produce ulceration. But we have better methods, and now they are available in smaller towns. Duplex scanning you can get done if you are too busy in doing the not doing the peripheral vascular examination yourself. Neurological assessment can be done by various methods. 10 gram monofilament is a crude method by which you can do this testing in your OPD and the bedside also. It is applied at 10 point of the foot on dorsum and plantar aspect, and if patient is not able to differentiate or pick up sensation at 3 point, you put this patient at risk of developing neuropathy. Then tuning fork test to understand the vibration sensations in this feet. But one simple equipment is now available and cheap also. Is a vibrothermometer. This is very simple. You can train your staff in the OPD, just a staff nurse or even attendant. The temperatures are adjustable. A patient will come to know at what temperature he or she is feeling the sensation, and immediately you can grade that, yes, this much is the impaired temperature sensation, this much is a impaired vibration sensation. So you can come to know about that. Musculoskeletal, you will first have a look on the foot. You will see there is an altered architecture of the foot, so you will get that idea from there. This is assessment for the foot pressure. This mat which is attached with a computer. The moment person is standing on this mat or walks on this mat, the computer picks up the impression, and it shows red areas are high pressure areas. So accordingly you can modify the footwear in these patients to avoid ulceration. The structural abnormality they do produce, like callus, which most of our physicians they are taking care of. Nice that they have taken this initiative, but if you see, these are very high pressure area, and if the callus is not removed or callosity is not removed, it's a high pressure area for the ulceration formation. So management has to be according to the general approach. You have to see whether it is infected, non-infected, is ischemic or combined ischemia or the. So ultimately if you see, depending upon that grading of infection, in diabetic foot we grade the infection in mild, moderate and severe. Mild can be treated on OPD basis with oral antibiotics. A moderate requires some admission for some time with the injectable antibiotics. Then we shift to the oral, and the moment patient improve, you can send the home. But severe infections, they do require the admission, and longer stay is there. This, remember, very high antibiotics are required in diabetic foot infection. These are mostly polymicrobial infections having a spectrum of various microbial flora, so that needs to be covered with higher antibiotics. That's why it is one of the costliest and very difficult complication of diabetes to treat. Follow-up of care and ulcer prevention has to be kept in mind. Once ulcer has healed, it does not mean that this patient is not going to have ulcer again. Almost 30% chances are that this patient will come back to you with a ulceration, because there is a change in foot biomechanics in this patient. Always a coordination team is required. This is ideal setup, but no setup can have a complete team here. Local care, debridement, dressing, adjunctive therapy, negative pressure wound therapy, which we will take up in discussion. Offloading also we will take up in discussion. Mechanical or other type of offloadings we will discuss about that. And a few slides Dr. Raizada has also added to the offloading. So you can observe a lot just by watching. You have to see if there is a callus, remove it. If there is a prominent bony area which can be removed, it should be removed to take away the pressure. And then offloading can be done by even simple removal of callosity. Sometime which is beyond your scope, tendon this lengthening procedure, Achilles tendon, when it becomes because of glycolation, it becomes stiff. There is a forefoot ulceration in these patients because the dorsiflexion of the foot becomes restricted. So person walks on that forefoot and it gets ulcerated. So we do that procedure. We have a thesis on that also. There is surgical correction of skeletal deformities. Then there are so many other techniques. You can enhance the plantar fat pad. And then infection, as I already told you, debridement, antibiotic, and all those things you have to do. If ischemia is there, unless until you revascularize, the ulcer is not going to heal. So this is the center where I work, which we established in 2006, I told you in the beginning. And this was the case only yesterday. This case had come to us, a young male with this situation. He is under treatment, presently admitted with us. We are trying to do our best to save this foot. Remember, it is better to have a deformed foot than the prosthesis. That is the philosophy. And our emphasis should be to save the foot, not to amputate the foot. There is a drastic change in philosophy. It was a neglected branch almost 20 years back. It was nobody's baby. Neither physician nor surgeon they used to touch diabetic foot patient because they demanded lot of care and lot of time. But there is shift in the mentality, and the industry has also come up in a big way in the management of diabetic foot. It has become a big revenue generation source for the practitioners also. But unfortunately, the things which they should not be doing, they are doing. That also is our responsibility. Where is the actually line? The physician should stop, and it should the domain of the surgeon to do the thing. So if you don't offload after treatment, the person is going to walk to death. Thank you. We will continue discussion on this. Thank you, Dr. Nagesh.
Thank you for the overview, sir, and rightly put, emphasis should be on treating and salvaging the foot rather than amputation. The next thing is, I would like to ask Nishant, what do you think are the endocrine reasons why this particular foot is not healing well?
Thank you, sir. So if you look at the systemic factors, those are predominantly more of the endocrine nature. So you have glycemic control. If the patient is having high blood glucose, then that can delay the wound healing. So that is one reason. Second is anemia. Anemia can cause a situation of relative ischemia. The amount of oxygen that is going to the tissue is a function of how much blood is flowing there and how much oxygen is there in the blood. So if you have anemia, again, that causes a reduction in the oxygen supply, and that will delay the wound healing. Another factor which is important is the nutrition. To heal a wound, you need to lay down new tissue, and new tissue requires protein. If you're eating very little protein, then it is very difficult for the body to heal the wound. And some micronutrients such as the vitamin C, vitamin B12, magnesium and zinc, etc. may also have some role in the wound healing. So a balanced diet with good protein is also required. The local factors sir has already discussed, so that we can skip.
And what is your perspective on diabetic neuropathy contributing to this problem?
So as sir was discussing, the foot has got areas which experience more pressure than the rest of the foot, such as the heel and the head of the first metatarsal. Now in diabetic neuropathy, the patient cannot appreciate any pain. So if there is there ulcer at these pressure sites, the patient will walk without any pain. On the other hand, a person who has not got neuropathy will limp because that ulcer is painful. So because of this reason, the trauma continues to occur at the site of the ulcer, and whatever healing occurs, that is negated by this trauma. So this is how the ulcer doesn't heal.
Now, I'd like to skip a couple of questions and ask you, as an endocrinologist, what are you going to do to heal this wound?
So in this particular patient, glycemic control is very important. We want to achieve a normal glycemia within days, not within weeks or months. Therefore, if the patient is already on oral drugs and the glucose is not at target, it is clear that straight away we should move to insulin. With insulin, we can escalate the dose quickly, and within few days we can achieve a euglycemia. This particular patient is already on 3 oral drugs. Very unlikely that she will achieve euglycemia with adding more oral drugs. So we should straight away add insulin. Probably basal insulin would be a good option in this patient because the fasting is primarily which is elevated. The postprandial is less relative to the fasting. Then comes to the question of use of insulin. So if the patient is not controlled, as I said, then definitely insulin should be started immediately. If the patient has got a wound which is very advanced stages, it's showing too much necrosis, or there is ischemia, or there is infection. In those conditions also, there is some data to support that insulin will improve the outcome as compared to oral drugs. And then if the patient has got a good glycemic control and the wound is small, it is healing well, in such cases it is not necessary to put insulin, but there can be some advantage if it is a long-standing wound and not healing, then there may be some advantage by starting insulin.
Perfectly put, but I'd like to digress slightly. In this case, I'd probably be happier managing it with at least twice daily insulin rather than putting it only on basal insulin. Might just not be enough. And the additive advantages of insulin as a growth factor would help you only if you're putting them on twice daily insulin rather than once daily.
I agree with that.
Yeah. Sir, how would you manage this wound from a surgeon's perspective?
If you see the toe, it is a neuroischemic foot. So
Yes.
the one investigation which every patient should undergo is X-ray foot. In this patient, you have not mentioned about the X-ray, and I am very sure from the look of this particular toe, there is underlying osteomyelitis. So this toe requires amputation. Remember, for avoiding major amputation, one must not hesitate to do minor amputation. So this is a neuroischemic lesion. This toe will require amputation, and that amputation has to be ray amputation, including the head of first metatarsal, and the rest Dr. Raizada has already told, glycemic control and everything.
Sir, and what are the kinds of dressing you would recommend in this, and would you recommend negative pressure wound therapy?
This particular, after you have done the amputation, if there is lot of ooze from the surface, you can certainly use VAC. VAC is nowadays very effective, but it is not meant for all types of wound. If the wound is not having too much of discharge, the VAC can be avoided. Secondly, the dressings. There are so many dressings which are being marketed, and this is industry driven profession now. So avoid those costly. Majority of these patients are from very low socioeconomic status. So we simple dressing with the saline and the simple ointments is very effective. The only thing is that you should not be using, once the wounds start granulating, you should avoid solutions like povidone, iodine, Savlon, otherwise that will kill the normal granulation tissue.
And negative pressure wound therapy, sir?
That I have told you, only very high oozing wounds, not otherwise.
And these other adjuncts like use of growth factors, hyperbaric oxygen therapy?
They have a place. Again, the cost is a major factor. PDGF is there, EGF is there, and other growth factors are also being launched in the market. But in very chronic wound, if you stimulate, because chronicity happens because of the lack of growth factors in that area. So if you supplement with the growth factors from outside, they do promote healing. But you have to weigh the cost and effectiveness simultaneously.
And because time is running out, I'd like to invite your views on one last concept, offloading, both from Nishant and Dr. Atri.
If the ulcer is in the pressure bearing area, it is not going to heal unless until you offload. Dr. Raja.
So as Sir has very well described in his talk also, there are some areas on the foot which are at increased risk of pressure because of either the abnormal biomechanics or the motor neuropathy. Now if the ulcer is in these areas, what we want to do is we want to distribute the pressure from this area to the rest of the foot so that this area receives the minimum pressure when the patient walks. So this is the basic idea behind offloading. And the various options for offloading, the three important ones are probably, the first one is a total contact cast, which is basically a plaster cast, which is a sort of a below knee cast. And what it does is that it gives a large area of contact for the foot. Now you cannot move your ankle, so you can't, put pressure on your forefoot or on the heel. The pressure is evenly distributed throughout the foot. So this is one option. Then the second option is a removable cast walker. It is just similar like the cast previously, but this is a removable device and this is relatively easier to use as compared to the cast. And the third option is that they are customized footwear. So there's just a wedge shoes, so that you have a ulcer on the forefoot, you can have a wedge which is removed from the front of the shoe, so that you don't put pressure on that part.
And this, I think you already spoken about this. Foot assessment, I think you already mentioned foot assessment.
I mentioned that.
Maybe
I think we can ask few questions from the audience if you permit.
Yes, sir. I think we are done with the presentation and we are also done with the time. We got 5 minutes for the audience to ask questions. Yeah, please go on, sir. Can we have a mic here? Somebody with a mic here?
Good evening, gentlemen. I am an orthopedic surgeon, and as Professor Atri said, physicians don't pass on the cases to the surgeon, and surgeons don't pass on the case to the orthopedic surgeons. So here is the case, the one which you have displayed, a bad foot, a smelly foot, a family doesn't tolerate it, the wife doesn't tolerate it in the bed, it keeps on leaking all the time, a lot of money on the purse spent, and it never heals. Professor Atri said it's 30-35% recurrence, a lot of money spent, and it never becomes better. Whatever footwear you have shown are all shown on the normal feet, if you see. They are not put on any diabetic foot. So this is again a market strategy to sell off the products. So I would recommend a person who has had a bad foot like this to do a below knee amputation straight away, because the person will get better in about 2 weeks' time. We have known people who have climbed Mount Everest with both feet amputated. I've seen people who learned on the newspaper, they've crossed the jail and crossed the walls. So amputee with a beautiful prosthesis which have come up in the market is a very good alternative for a person like this. Thank you.
Sir, I totally disagree with you on this particular point. This is a very radical view and audience should not take this at all. And the face value of it. It is very easy to say amputate anybody's foot or leg or do below knee amputation. It is so traumatic for a person who is offered this. Always, I told you in my presentation, it's better to have deformed foot rather than a prosthesis, because if you have whatever best quality prosthesis you use, it increases your basal metabolic rate, it increases your effort in walking and everything. So kindly, this mindset should change. That's why diabetic foot specialty has totally become a different specialty. So no amputations at all. Only I said minor amputation to avoid major amputation. Like in this lady index case, Dr. Nagesh, toe amputation to avoid below knee amputation or foot amputation.
I concur with you, sir, as far as that is concerned.
Yeah,
absolutely.
I think he might not be satisfied, but I am very clear on this.
You can always agree to disagree, both of you.
Yeah, that's what the purpose of meeting here and meeting in the conferences.
Do we have any other questions from the audience? Yeah. Yeah.
Madam, there are so many solutions and simple dressing materials now available. Simple saline dressing is also very effective. Why I said you should not be using? Because they are tissue-cidal. Povidone iodine, cetrimide, which comes with the name of Savlon and all those things, they don't let the epithelium grow over the granulation tissue. So once the normal granulation has come, there is no role of these hydrogen peroxide or all these things. Only simple dressing with saline, or you have products like Hydroheal and all, which are not very costly. Even you have Oxum superoxidized water that can be used. Very simple and simple dressing patient requires.
Do we have any other questions?
One thing which I like to add, footwear, special footwear in these patients. And I request all the physician colleagues, at least appoint somebody in your OPD if you are very busy to ask the patient to take off the shoes and socks, have a look. If you are not having time to examine, refer to a nearest surgeon who will examine in proper and will avoid this problem of ulceration. Secondly is that all these patients, sometime they require special footwear. So not in all places they are available, but in city like Delhi, in Chandigarh, now these are custom made shoes are being made, then they can be very, very helpful in avoiding this catastrophe.
If there are no further questions, I'd like to thank both the speakers, Dr. Ratri and Dr. Nishant Raizada, for being a part of this meeting, and I'd like to end the session here.
Thank you. Thanks, sir.